There can be no quality without health equity, but how do we get there? Welcome to Quality Matters, the podcast where we dive into the future of healthcare innovation and quality with the experts and leaders who are shaping it. I'm your host, Andy Reynolds. Our guest today has unorthodox ideas about how to achieve health equity. He is University of Chicago professor Marshall Chin. His solutions to health equity might surprise you. Welcome to Quality Matters, Dr. Chin.
Thanks for having me, Andy. Appreciate this.
I want to start with maybe the most intriguing bio I've ever seen. Dr. Chin uses improv and stand-up comedy to improve training of students in caring for diverse patients and engaging in constructive discussions around systemic racism and social privilege. Improv and stand-up comedy. How does that enter your teaching?
Yeah, it's kind of a fun story. About 7 years ago, my wife and I, we ended up starting to train and perform in both improv and stand-up comedy. We realized that the skills we were learning translate well to the day job. And so we've used different exercises from improv. And one of the key challenges is having honest, frank discussions about difficult issues like structural racism, power, privilege, other systems of oppression.
And so what's different about your approach compared to what medical students or other people in the profession might find at other institutions that don't have this comedy or improv angle?
This all started about 3-4 years ago during the pandemic. There's a required course on health equity for all the first-year students at the University of Chicago First-Year School of Medicine. It's a great course that's been run for over a decade. And it involves a variety of lectures and discussions and community work and all. The feedback every year is that students want more and more discussion, more and more small group opportunities to delve into issues in more detail. And what happened with our pilot was that it was all very experiential. So no lecture and jumping right into the exercises and the discussion and the reflection by students. And yeah, it's the difference between hearing a lecture about equities and then just jumping right in and doing it. Improv, for example, a lot of skills have to do with how do you become a better active listener and how do you be there in the moment with your scene partner or patient, right? Because sometimes, like clinicians, we just have a script in our head that the set of questions we need to go through. And then oftentimes we don't really listen to that patient, are with them where they are, as opposed to trying to impose our own agenda, our own medical agenda upon the interview and the appointment.
To improve health equity, Marshall Chen says we need to update our basic ideas about quality improvement.
Definitions are important. A lot of the healthcare world still comes from what I would call a health disparities perspective. Clinical metrics stratified by a social risk factor like race, look for these differences, and then try to reduce those gaps. So making sure that everyone has a fair and just opportunity to be as healthy as possible. If you go from a pure disparities lens to a health equity lens, in some ways you broaden your vision by the overall field, including NCQA, at looking at health-related social needs. That is critical to address both the more healthcare-centric things, like providing care that's tailored to meet our patients' needs, as well as to address, again, the medical and the social. In a sense, all of this is avoidable. We have the healthcare system we have. It's not just by chance. It's an intentional decision that we have structured the healthcare system in a way that it is structured where those who are less privileged have trouble accessing care. They don't have good health insurance. Or in general, we have too much of a one-size-fits-all approach to the healthcare. Something like interpreter services, right? A lot of places just don't have great interpreter services. Or most places don't have well-resourced team-based care. We have a team to be able to address then the combination of medical and social factors, to partner with community for addressing some of the social drivers. So a lot of our so-called health disparities and health inequities really are avoidable. We just need to do a better job as individuals and as the healthcare industry and really as a society in prioritizing advancing health equity and making sure that's done.
Another term our audience may be familiar with is systemic racism. And I'm wondering, how does systemic racism contribute to ongoing disparities? And how does systemic racism interact with other kinds of racism that researchers have defined or that people may experience?
Traditionally, a lot of health equity training has been at the level of interpersonal discrimination, interpersonal implicit bias. So, cultural competency training, cultural humility training. The newer thing and the harder look is the inwards look, both within ourselves as well as within our organizations.
Being more clear about basic concepts of health equity also means being more specific about how we define racism.
There are different types of racism. Probably the most widely used conceptual model is the one by Kamara Jones, who's a great health equity expert, and talks about there's intrapersonal racism. So the example that Dr. Jones uses is that white man's ice is colder. The idea that, oh, because it's the white man's ice, it's got to be colder, it's got to be better. That's an example of internalized racism. There's interpersonal racism, which is the one that most people think about regarding discrimination. And then there's the structural racism, which are that, whether inadvertent or on purpose, are racist in effect.
Marshall explains that really seeing people in all their complexity starts with meaningful, specific categories for race and ethnicity. Marshall and I spoke in May, which was Asian Pacific American Heritage Month. So our conversation focused on that demographic designation. However, as Marshall points out, that label is problematic.
The categories of race and ethnicity are too broad. I'm third generation Chinese American. My grandparents came over from China early 1900s. We're aggregated. Countries as diverse as Cambodia, Japan, China, Philippines, Indonesia, an Asian American census category puts everyone into a hole where you miss the inequities, basically making Asian countries and people of this faceless mass. Part of the reason why is that there's this model minority myth. There was all these Asian American discrimination laws. Well, 65 was the immigration law that did open up immigration. For Asian countries, it prioritized highly skilled professional workers. So then the numbers of people that have immigrated were then overweighted in terms of health for professionals and people with skills. If you are a Chinese immigrant that doesn't have professional skills and you're going to look in a low wage job in Chinatown, you're invisible in aggregate statistics. A lot of the Southeast Asian countries, so the Cambodias and Vietnams of the world, they oftentimes have health inequities. It sort of waxes over in the heterogeneity and the disadvantaged populations within the Asian American subcategories. There used to be this Asian Pacific Islander category where Asians were lumped together with Native Hawaiians and Pacific Islanders. But again, very different histories. If you basically aggregate it into the overall Asian American category, you miss that.
Marshall cited other examples to clarify that overly broad racial and ethnic categories make it easy to overlook important details.
We need to do a better job of looking at an intersectional approach to equity. If you're a rich African American, there are clearly issues of race that are important, but it's a different situation than if you're a poor African American, or if you're a Latinx person that comes from a sexual gender minority category. There's a different lived experience than if you're a heterosexual Latinx person. It's important to think about the more granular level is intersectional issues, because we really are the product of a rich set of intersectional identities. We need to look at people as individuals and address both the individual and structural issues that reflect these different identities. Race and ethnicity is one cut at things. You have to look at this granularity.
For another perspective, we spoke with Dr. Rachel Harrington, who is NCQA Assistant Vice President for Health Equity Sciences.
Dr. Chen makes a really great point about the fact that none of us exist in a single box. We all come to the table with a number of different identities, different lived experiences, and that colors the way that we experience our healthcare, the way we access our healthcare, and the healthcare outcomes that we have. So as our data is evolving alongside this, we have to understand where we can build that nuance in. And granularity is one step along that path, understanding that one identity has multiple different experiences. Where are you from? What is your cultural background? What are the languages that you speak? And by allowing our data to reflect that in more detail, we really can have a better understanding of the experiences that people have and meeting populations where they are. There's another element here around the trade-offs that we make when it comes to data at the national level. In individual communities and populations, we might want more granular data to understand the specific relationships and communities that are being served or worked with. But when we report data at the national level, we might lose a little bit of that detail to gain the ability to speak to experiences across the country, which might be more diverse. And so we have to navigate that trade off carefully, making sure we're retaining as much detail as possible while also being able to draw conclusions that help us make policy and program decisions for a national audience.
Rachel Harrington has ideas on that. She mentions the Office of Management and Budget, or OMB.
And I think you see the data standards that the Office of Management and Budget put out really trying to navigate that in terms of increasing the granularity that is the baseline standard for data collection, using those more detailed categories as the default, but also including some of the roll up categories to facilitate some of that larger policy evaluation. We've talked a lot in NCQA's work about race and ethnicity data, but Dr. Chen's point around the experiences that happen at the intersection is really critical. We're not all one box, we're not all one identity, and the experience of somebody's race or ethnicity, their sexual orientation, their gender identity, their cultural background and heritage all come together to shape how we experience our health care and the types of care that we receive and the types of outcomes that we're likely to have. And so, one of the things we navigate in quality measurement and in our standards is how to work at that intersection effectively. How do we make sure we're getting reliable, consistent measures of quality, but also understand that these dynamics are not one sided and that we do have to account for multiple factors when we're looking at what outcomes look like?
Marshall is optimistic about health equity because it has the support of so many in the medical profession and among the public.
Well, I think that I would ask listeners to follow their hearts and to really just remember what was it that got them into this healthcare space in the first place. And I think for the vast majority of people, they really are doing it into getting into this area because they want to do the right thing. You ask a clinician why they enter this field, they want to help people. And I think that for the vast majority of people, the vast majority of the public are really good people that want to do the right thing. If that's the way it is. When you poll that question about health equity, fair and just opportunity for health, it's about 2/3 of the American public agree with that. There's a lot of shared vision and values. Again, you look at all the polling, 2/3 of the American public support having a fair and just opportunity for health for everyone.
Part of the reason why people generally support health equity might be that deep down, they know equity helps everyone.
A classic example is persons with disabilities. If you just have a curb, it's hard for a person in a wheelchair to get over that curb. It's hard for a family with a stroller, but you have that little carve out in the curb. It helps everyone. Solutions that lead to more equitable care, more equitable outcomes. These are, in general, the things that lead to a better healthcare system that's more tailored to meet the holistic needs of all of us. Equitable approaches benefit everyone.
If both the medical profession and the public support health equity, why is equitable care so elusive? What are we doing wrong?
The problem is the current system basically is rewarding profit that is not aligned with maximizing individual and population health. Payment and health systems are not set up where at present is a good business case for advancing health equity. Equity is not rewarded under the way our current both public and private systems are set up. It's the type of care that clinicians would love to provide, but systems aren't set up in a way that enables this. There's a lot of value in equitable reform, but the individual hospital or insurer systems are not set up in a way that creates a good business case. This is care that any person would want to have our medical and social needs addressed. This is what clinicians want. They went to healthcare because they want to do the right thing. The healthcare industry wants a business case to do the job they signed up for in the first place. It's a good societal case. This is what people know intuitively. The problem is that we have not set up the rules where people should be incentivized to maximize the health of communities. So the challenge is how do we align the incentives, make it a business case to basically advance health equity, to support and incentivize these equitable systems. Money is just such a powerful driver of what we do that until the business case aligns with equity, there's going to be a limit. We need to do a major realignment, prioritizing true value to help patients and maximize community health.
What about implementing policies that advance health equity? What potential pitfalls do you see there?
One of the wider problems is we are not intentional about designing our solutions to advance health equity. We have the rising tide lifts all boats type perspective that we're going to do general quality improvement intervention or some general intervention, assuming that that will also reduce inequities. Have to understand what is driving the inequities and then specifically tailor the solutions. Part of the problem is that it's not culturally tailored. The messengers aren't the right messengers for health education, or we don't do a good job of bridging the worlds of the patient between the healthcare system and what's at home.
The point that Dr. Chen makes about rising tides lifting all boats, maybe not getting us where we need to be in terms of reducing inequities or disparities, is a really important one. We have this concept in quality improvement of tailoring solutions. It's part of our quality toolkit that we all go towards, making sure we understand the populations we're working with. We're understanding clinically where they're at, socially where they're at, contextually where they're at, and really focusing our interventions to meet people where they are. That's part of what quality intervention is, and we can apply those same skills, same tools, same expertise to our work in equity. This also speaks to the point of whole person care, meeting people where they are holistically and intentionally, and understanding that whole person care is more than just your blood pressure or your A1C or your clinical elements. It's also who you are, the background, the perspectives that you come in with, the systems and structures that have influenced the care and experiences that you've had in your life so far. And so if we really want to achieve whole person care, addressing questions of equity, of identity, of disparities is really critical to getting to the outcomes that we want to have.
Marshall goes on to explain that helping health equity succeed is the ultimate example of multitasking, a challenging mix of very different disciplines.
There are technical things involved in reforming the payment system to do a better job of supporting and incentivizing health equity. Besides the technical things, you're not going to get very far unless you also address a culture of equity and anti-racism. Part of it is having these honest discussions. That, as a country, we're not particularly good about having honest discussions about racism, power, privilege, other ways of marginalize people.
Even if people know they want to improve health equity, they often don't know how. Marshall has suggestions.
People will then say, love the training, love the discussion. Now, how do I operationalize that in my daily job? What can I do as part of the wider team of people to think about the intentional things to advance health equity? A lot of it is just common sense and just breaking it down into the simple one-step processes. I like to break it down by saying, look at your data. Where are there inequities? Next step, why do inequities exist? Work with your frontline staff, work with patient communities who know the answers best. Once you've identified those drivers, then in whatever your solutions are, make sure they address the problem that is driving inequities. It's never one thing. It's a multiple factorial things. So it requires a multifactorial intervention that addresses each of those major drivers. On one hand, it's a complicated problem. On the other hand, it becomes very basic and very sort of methodical regarding just that simple, like one step at a time. But it has to be thought through as a whole in an integrated way. And it really is a team sport.
To achieve equitable health outcomes takes a range of different strategies. One activity is not going to solve this, but we have a lot of things we can bring to the table here. We have tried and tested quality improvement. We have quality measurement. We have structural requirements, really setting the systems and structures in place to get us where we want to be. Incentive designs, what are we paying for? Where are we putting our resources to support healthcare providers, to support systems, to support communities in achieving their best possible health? And we also have partnerships, which is a critical part of achieving equity outcomes. Understanding that the people who are closest to the community are probably going to be in a better position to address some of the unmet needs than somebody who's further away. So understanding your population, understanding race, ethnicity, language, disability, sexual orientation, gender identity, lets you understand where your partnerships need to be, who your partnerships need to be with, and then really bringing that to the table alongside all of these other tools to really get momentum and take action and make change.
Marshall is adamant that improving health equity requires a comprehensive approach. We can't focus on certain areas and ignore others.
People will often ask for the shortcut. There is no shortcut. Like a lot of so-called complex, wicked problems, there's not going to be a magic bullet solution. They say, we'll try to do this as cheaply as possible. What's more important, doing the care intervention, doing the payment part, we think, well, okay, VBP, value-based payment and alternative models, they got to be better than the fee-for-services. Or people say, well, let's just do the technical stuff. Let's just look on care transformation and quality improvement and think about our payment, for getting the whole organizations involved and bought in and all. You have to do the cultural part simultaneously. You have to have a discussion about anti-racism. You have to have the training in on discussion about that at the same time. You have to work on the technical part, like the care transformation, the payment part. You have to involve the patient communities authentically and have them as equal partners, share power. You have to address the cultural equity, that type of training, the anti-racism part. They all go hand in hand. It's an integrated model. It all fits together. And then the metaphor I like to use is like a balloon. You do one thing, the balloon's going to push out in a different way. So unless you think about the system as a whole, it's going to be really hard to find a solution because, again, you do one thing, you push the balloon one way, but it just pops out another way. It's so important to see people for who they are. There's just so much heterogeneity. People have to be seen for themselves as individuals, and we can't just blindly put a label that's not accurate and just ignores important populations that have great disadvantage. Part of the solutions are to disaggregate data. A lot of people don't know what to do or how to operationalize this.
So, really understanding people means parsing demographic information into finer, more meaningful categories, and expanding our definition of what counts as data.
It's really important that we think about data both in terms of quantitative data and the importance of disaggregating data, but also qualitative data is equally important. Storytelling is just so important. It is that combination of the storytelling and the aggregate quantitative data which will lead us to the most holistic, accurate view of these inequities and solutions, to hear the stories of lived experience, to not just other people into some aggregate category that doesn't make sense. One of the most powerful ways is with our peers and hearing the experiential stories of people's lived experience. It's so powerful. The humanities, things like the improv and the stand-up, because it gives groups to have that kind of honest discussion and sharing. That's the most powerful way of learning. The two have to be combined, and that's the most powerful and most accurate.
Marshall makes clear that health equity is everybody's job.
You can't just marginalize it to the DEI justice group. I mean, the thing about health equity is that it's the right thing. Everyone wants to do the right thing. And then I think that the fun thing about it, too, is that it requires all this expertise and all these stakeholders. It has the community expertise, and it requires the clinicians on the staff who have the frontline experience. It requires people who do quality improvement. It includes the data people. I mean, everyone has a role. That's what makes it this so exciting, and that it's going to require all of us to do it. Everyone has to sort of play together. The dots all have to connect. It's a team sport. If you want to have sustainable change at scale, the whole healthcare organization, the whole integrated delivery system, the whole payer, the whole health plan have to be involved. The thing I'm curious about and I'm excited about is that ultimately it all has to fit together. And this is where leadership comes in to say, hey, this is important. An individual hospital or clinic can do their thing, but at a certain point in time, there's only so much they can do unless the business case aligns, which means the health plans have to do their work. The payers, whether it's the Medicaid payers, whether it's CMS, the private payers, they all have to do their part. And ultimately, all the levels have to be integrated and aligned.
Marshall, we're about to wrap up, so let me ask one more question. Where can people go to learn more about health equity?
I'll mention 3 buckets. One is this work with CMS, the Centers for Medicare and Medicaid Services. They have a healthcare payment, learning and action at work, health equity advisory team. So if you Google LAN, L-A-N, HEAT, H-E-A-T, you'll come to the health equity advisory team's work. The first is a white paper on general principles and using alternative payment models to advance health equity. A second bucket would be, if you look at the website for our Robert Wood Johnson Foundation programs, advancinghealthequity.org, we call it the VBP checklist, which gives you a very practical approach for thinking about your payment levers, your care transformation levers. For those who want to have more of the broader social background for it, there's a great paper reference on our website where we talk about the application of an anti-racist approach to care transformation and payment reform. The third bucket of things I would point to, the book called The Sum of Us by Heather McGee. And she outlines, just like as in the Kirby example, of like solutions that work for persons with disabilities benefit everyone. The whole argument for we progress further if we unite and think about solutions that benefit everyone
Our final question, Marshall Chen, where can people go to learn more about you and how can they follow your work?
So I'm not someone that has a website and that has all this on. I think probably the best places would be if they just Google Marshall Chin, they're gonna. It's interesting. Two people come up. The more interesting person is a restaurant owner in Detroit who has a very interesting background. So he'll come up with some of this stuff. But the other stuff is about me. And I'm a journalist, so I'm all over the map so that you're going to find things that really cover the spectrum from, the arts and humanities. We talked about improv and stand up to some of my work's more ethics based. So I write about, and I know like some things you were going to potentially ask me about. I've written, for example, about the ethics of health equity. And for example, one of my teachers in college was a woman named Judith Sklar, who's an amazing scholar who writes about cruelty and health and equity and all. And so I have a piece, for example, that talks about cruelty and health and equity and draws upon that. To some of my work, just very technical regarding, for our audience here, what specifically can we do regarding payment reform and care transformation and all. So I would just suggest people can Google me, they can do a PubMed search on me and just browse that, no matter your interests. Again, I have the blessing and curse of the generalist, being interested in a lot of different things. I think you can find it interesting to explore. And I think, again, it's the exciting thing about health equity that to be able to make the most advances, we have to get better and bring expertise together of all these different fields. And one thing I try to do in terms of lifelong learning is to surround myself with people that know a lot more about me. So I've learned more about these areas that I've been relatively weaker in. But I think that's the fun thing about a team sport. So I really explore people that, in some ways, if you just Google me, that will be a fun way to have an entree into the wide variety of fields that over time to get experience in to get better at advancing health equity.
Well, we will link in our show notes to the resources that you suggested, and we will link in our show notes to the many places on the internet where people can find you. As you said, you are a generalist, remarkably well-traveled or broadly represented on lots of topics and on many platforms. So Marshall Chen of the University of Chicago, thank you for being with us. Thank you for listening to Quality Matters. You can always learn more at ncqa.org, and be sure to subscribe to Quality Matters wherever you get your podcasts. We'll see you next time.